Hi everyone, this is Lian, and this is From the Heart. And today I'm going to do a little mini episode just on marginal cord insertion and some controversies that exist in my head and in the world of evidence, but not in the world of practice. So this is, it's just a crumb. It's not even a sliver of the pie. If I was to do an episode on ultrasound, it would be huge. It would take me months at the very least to make. So I'm just going to take one aspect, and then I'm gonna just do extra episodes rather than one huge long one where at the end I can't even understand myself. So so that's what I'm going to do. I will define what a marginal cord insertion is and what's happening in the world of evidence and why it is considered controversial in that aspect, the world of evidence. So I'm going to pull out my placenta here. Did you think that infection control would get me and put me in jail today? I don't think so. That's not what I have in my freezer. So this is my dinner plate placenta. And this is just going to represent the placenta. And my hand and my arm are just going to represent the cord. So basically, when you have a placenta, it is usually circular-ish. Maybe not as wide as this, maybe just like a little less from my fingertips to my fingertips here. But they do vary in sizes, and the cord somewhere is attached somewhere on the placenta. What the cord has 3 vessels, and then those 3 vessels are surrounded by Wharton jelly, and then that cord goes to the baby's umbilicus. So those vessels either pass blood to the baby or bring back blood from the baby to the placenta to the mom, so that baby can get all its nutrients, including its oxygen. And what do we know about the placenta? Honestly, science hasn't made it to understand all of it, which is actually really good. That we don't know everything. We're not meant to know everything, and to know everything could lead into some unethical things. So for the insertion of the placenta, usually the placenta and the cord are attached somewhere. The definition of a marginal cord insertion in the world of practice is that the placenta is attached within 2 centimeters of the side of the placenta. So that is a marginal cord insertion in the world of, when we're working, when we're ordering ultrasounds, when we're receiving ultrasounds, when we're looking at ultrasounds. In the world of evidence, the definition, there's 3 definitions. It could be either 1 centimeter away from the margin or the side of the placenta. It could be 2 centimeters away from the side of the placenta. It could be 3 centimeters away from the side of the placenta. So those are things, but in general, what I understand it as, just because of practice, is 2 centimeters away from the side of the placenta. So in the world of practice, there is a recommendation that if a cord is defined or has been measured as being inserted within those 2 centimeters of the side of the placenta, then the midwife or the doctor receives that report and then recommends further ultrasounds in the pregnancy, because the baby is deemed at risk of not growing very well in utero for the remainder of the pregnancy, especially in the 3rd trimester. When we look at the evidence, the studies that suggest that babies don't grow well in utero are always mixed up with another risk factor, or another, I don't want to call marginal cord insertion a risk factor, but The other one is, so so what they mix together, they put it in one group. They put in one group the marginal cord insertion and velamentous cord insertion within one group, versus people who have more central insertion of the cord. So central insertion is just like a cord that's like attached here in the middle of the placenta somewhere, not within the margins or the sides of the placenta. A velamentous cord insertion, this is important. So like there is a huge difference between a marginal cord insertion and a velamentous cord insertion. So velamentous, imagine that this was the cord, my arm, and then these were the three vessels, or even just one of the vessels, just coming out without any Wharton jelly around the vessel. So now there's no protection for the blood to go from the placenta or to the placenta to the baby, or whatever. Anyways, you know what I mean. So imagine this is the cord, and then there's like some vessels that come out, and then they attach like this to the placenta, and there's no protection. So that is a risk factor that can affect labor, that can affect growth. So, and it affects those things so much that when you mix them up in a group with marginal cord insertions, you see that that group of babies has a risk factor to not grow well in utero. So anyways, I noticed that the studies would mix up these two groups together. And then I was like, okay, so what if we only look at babies with marginal cord insertion? Would that be a risk factor on its own? Because they're two different things. Different things. And then, because, anyways, so what I'm trying to say is that marginal cord insertion, when it's studied on its own, is not a risk factor, at least from what I saw. It's not a risk factor for babies that don't grow well. Velamentous cord insertion is a risk factor for a few different things, including the baby that's not growing well. So these are tricky things, and like, why aren't we discussing these things with clients, and how research is done and how research can be fraudulent because the researcher wants the outcome to be something that is significant so that it gets published, and you know, all those things. Like, why aren't we having those discussions with our clients? Or not, we don't have time. It's not medically, legally even important for us to do that. It's medically, legally important for us to do the opposite, to do more ultrasounds. And so you're going to ask me, okay, well, what's wrong with doing more ultrasounds? More ultrasounds lead to more intervention. We see more things. Ultrasounds are not a perfect science. Sometimes we see things that don't exist. There's a high false positives with ultrasounds. There are also things that we don't see because it only sees in 2D, right? It's not a 3D kind of science. It is the only window inside the uterus. Like, I'm not saying that all ultrasound is bad. I'm not like, you know, it's really nice to know, you know, for most women that the baby has 2 kidneys and all of that. You know, we also don't tell our clients that, so that our, like in the heart, we only look at a few, you know, pictures of the heart, and ultrasound in utero only picks up about 10 to 30% of cardiac problems, for example. That's just like, you know, informed choice, in my opinion. So, and then there are other, you know, different, like kidneys, they see more problems with the kidneys. You know, they see more like 70% and more of the problems. So we just need to be more realistic about ultrasound. We need to be more honest about ultrasound, and the interventions that it can lead to. Usually it's induction. Like, that's the main intervention that is increased because of ultrasound. And we know, like, honestly, like, I know that there's one study that shows that induction doesn't increase certain kinds of interventions, but honestly, the rest of the research and what we see with our own eyeballs in the real world is that induction does lead to more intervention, and then those even intervention of induction can lead to some serious side effects. And not that all induction are bad, but just that the proper indication for ultrasound really leads to better outcomes versus not, right? And then with the rates of like the stats that we're seeing today, which is also increasing drastically in Canada, a country that is supposed to be developed, you know, in comparison to other countries. It's not acting like it, but the mortality rate has increased, you know, significantly, like very recently. And so this is an opportunity for us to look at all the little crumbs of things that we do that are not evidence-based. We are having a movement of free birth, where people like just don't even trust the system. They fear the system to the point where they actually say this, that they would prefer having the outcomes of what happens in free birth versus what happens in like the system of what we call healthcare. Anyways, I have a lot more to say about free birth, and I will do my own episode on that because I have more information than when I did my opinion episode on that. So I'll do that. We are being asked to be more honest. We are being asked to be more honest in research. We're being asked to be more honest when we provide information to our clients. And I will say, like, this is not like what I'm saying right now. This is not something that we are being taught as students in midwifery, or if you're a resident or a student in medicine. This is not something that we learn. It's not something that we are told. It's not something that we discuss. This is something that when you have your spidey senses up, you go and look for it, and then you're like, oh, the evidence is not there. So that is just the reality of what we need to work on. What a wonderful opportunity. We're being forced, right? We're being forced because outcomes are not what we want them to be. We have to move fast, because if we don't, then things are going to get worse. We need to go and look at these things. We need to stop seeing medical, or ourselves, if we are medical authorities or whatever you want to call yourself. And the clients need to also see this. The healthcare providers are only there to provide the care that they are told to provide in the ways that they are told to provide. So we have to have our own backs here. If you're the receiver of care, to use your spidey senses, ask questions, be the authority of your own health and your own life and your own body, right? And your care provider is here as an educator of what they know. They're not above you, they're not below you, they're not worse than you, they're not better than you, nothing like that. We need to see each other as like this. When someone is making a decision, if you're a healthcare provider, when someone is making a decision that is unusual, right? They're not following, like what we tell them to. We need to honor and respect that more, and we need to have discussions that are not biased, where we just lay out, here's the study. Those clients are smart. Like, clients are smart, even if they're on drugs. They're really smart. They want information. They want to be sat down with you. They want to know what happens. So we need to remind ourselves that we are smarter beyond what is just black and white and given to us. We need to potentially give the guidelines, the printed guidelines, go through it with them, and then take a few of those studies, show them why something is considered more important and why something is less important. And so what I was told is that in the UK, people see midwives, and then when a client steps out of what is regularly recommended, that client goes and spends time, it could be hours, with a special midwife, a midwife who, like, her job is entirely looking at cases of when someone asks for care outside the guidelines, and then laying it all out for her, laying it all out, what the real risks are, this way, that way, that way, this way, what the real benefits are, this way, like all the ways, all the options, including all the things that we don't know and the things that we don't, like, I'm hoping that that's how they provide information, things that we know, the things that we don't know, the things that are well evidence-based, the things that aren't well evidence-based, which there's a lot more of. Anyways, we can do better, and we can make the system actually trustworthy, not in a manipulative way, but in an actual way. And when people feel and sense the truth from you, they know. They might be, a little bit like on edge. They don't know who you are. They're not sure if you're going to try to manipulate them and tell them what to do and be an authority. Okay, they don't like that. Obviously, I don't. I wouldn't want to receive care like that, so why would I provide it? And of course, I've had, like, sometimes I have my own biases. So this, you can understand this if you're a care provider. You can understand this if you're, as someone who receives care. I have my own biases too. So if someone says something scary to me, I'm going to, not be in my best mood. You know what I mean? So, like, we're all humans here. We're all learning from each other. We can all do better. We can all stop seeing healthcare providers as authorities. That makes you a better person. Both ways, if you're the patient or the care provider. And then, if we just see it like this, so we're all trying to do our best. And that we live in a world where, honestly, okay, so, like, this is another thing about imaging. There's a lot of money that can be made from imaging. And not that money is bad. It's how we use money that can be good or bad, So are we taking advantage of the fact that women want to bond with their babies and see pictures of their babies to make money? So like, that would be manipulative. So these are all things that we need to consider. This is just one teeny tiny crumble of the whole piece. There's things that are really well done in the system of what we call healthcare, and then there are things that need work. They need work, and so I'm here to tell my piece around it, to not be silent and an observant of, like, silence is peace. Like, no, like, it's not. There are things that are going on in the world, and data is showing, even though data is not being put out there very clearly. We have to, like, really, like, go and look for it. It's very difficult to find, and honestly, good accurate data it needs to be mandated. Like people who collect the data in a way, especially the ones where, like, our tax dollars pay for it, there should be some clear guidelines of what is mandated for us to know. And what should be mandated is when we increase interventions and indications for interventions, it should be mandated that we look for, and that the data for the side effects, whether they're good side effects or bad side effects, that the side effects come out, that they are visible to the public, that they are visible to the researchers, that they're visible to the healthcare providers. Right? So if we have increased all these interventions, these indications for induction, let's say, because that has happened over the last decade, okay, we should be looking at abruption. We should be looking at uterine rupture. We should be looking at cord prolapse. We should be, like, that information should be very clear to everyone in Ontario, right? Like, it should be very clear, very just like this, right? So it should be laid out for us, is what I'm saying. So that should be mandated, so that we can work on making things better. If we know that cord prolapse is increasing, let's say, like, I'm not sure, I have a feeling, I have a good inclination that it is, unfortunately, but that, like, it's just an educated guess. It's a knowing guess. But the data from all of Ontario would be better. than just that, then we could do better. We could have better, clearer, we could tell her, the residents, like, you're not going to rupture her membranes, which means breaking the waters, until the head is well applied, blah, blah, blah. We would be stricter about certain things to make it safer. So we should be looking at that. And like those things, those risk factors that I was saying, the cord prolapse increases risks to the baby, mostly, unless if we're doing a C-section, which we would usually be doing, and then abruption and uterine rupture, which are mostly all rare, but they are increased with induction, have some significant side effects for moms as well. So that's just something that we should be looking at, and it should be very clear, laid out to us. It shouldn't be guessing games. It should be very, very transparent. And then we can make the differences. And then we can have clear discussions with our clients and have real information available to them, for us, and for them. So anyways, I am full of ideas. Do I know the solution to reduce like these really devastating data, like devastating outcomes? No, but like I don't have like the clear one thing, pinpoint that, but we can all get together and say, yeah, something needs to be done. And it's like really urgent and it's really important. And us as healthcare providers, even though I'm not registered anymore, but whatever, the fact that I have experience in this and that I have knowing and that is very important for me to speak out about that. It's actually, it should be mandated for me to speak out of what I see, my intuition, basically. And so that's what I'm trying to do, is just clear my heart. There are things that I know. There are things that I don't know. There are lots of questions that I have. That's what we should be doing. We should be getting together, having very transparent discussions. We shouldn't be doing things behind closed door, being, we should be very, very laid out, transparent, and what we think we can do. It should also be, the other thing is that we can be very simplistic in like pinpointing something. If we're pinpointing something, it's very simplistic. It's very simplistic thinking. And so the more that we look at everything that is not properly evidence-based, doesn't mean that that is wrong or right. It just means that we can have a clear discussion with our clients, and she can make a decision that suits her and her family and her body. And clients want information. I know that some people come into care and they're like, no, I don't want information. I want to do what I'm told to do. But those are the clients, like just a few months into their care, and you tell them, oh, like this is like the choice that you have, and these are the risks. Well, I don't want that. Or, oh, well, this is another choice. And then they want that other choice. Like people do want choice, even if they say they don't want choice. They want to know information. They want to be empowered, even if they say they don't want to. Eventually it comes out. Eventually they want that. So that's just a reality. Sometimes we don't think that we want choice, but we do in the end. Okay, that's my little blurb on the, the marginal cord insertion and Velamentous cord insertion. There is a risk factor to the Velamentous cord insertion where that cord, if it is in the presenting port, if like that, like not the cord, if the vessel, the blood vessel is like near the cervix, there is also this thing called vasa previa, and that is a much bigger deal. Thankfully, ultrasounds can pick up, and I wouldn't know like the percentage of what they pick up on and what they don't pick up on. It's not 100% accurate there, but that is also something that I just wanted to mention. That is something that is looked at in the evidence, thankfully. I really wanted to prove myself wrong here. And then I found like this meta-analysis. A meta-analysis is when you look at multiple randomized controlled trials, and in the title, it said something like, I'll post it in the show notes, but it was only talking about marginal cord insertion. It wasn't talking about velamentous cord insertion. And then it just said something like that do those babies grow well or not? And then I looked at the studies that they looked at, and then velamentous cord insertion was still involved. Like, it was still kind of put together with the marginal cord insertions. I'm like, can we like separate the two? Like, so anyways, there's definitely one study that I have. You'll see in my show notes, where a marginal cord insertion is separate and shows no differences in babies that don't grow well versus babies that grow well, compared to the group where people have more centrally inserted cords. So if you have evidence that proves me wrong, I would be really happy for you to prove me wrong. Please post that evidence, make sure that it is thorough and that we can have a proper discussion around this. It's a smart discussion. That'd be really nice. So have a really great rest of your day. Ask the questions to your healthcare provider. If you're a client with a marginal cord insertion, what is the evidence for this? You can look at the evidence that I post. You can bring that to your care provider. Maybe your healthcare provider has more. If your healthcare provider has more and it is smart information, please share it with me. I would love to be proved wrong. I hate that I'm posting all these things where I'm saying the evidence isn't there and that we're not doing things appropriately. I hate it. But the world, I owe it to the world to lay out what I see. So do that if you find stuff that is good to share. Okay, and then eventually I'll do another episode where I'll prove myself wrong, and that'd be wonderful. That'd be wonderful if that exists. Yeah. Okay. Or if you have more information that proves that I'm right, fine. I'll add it to the show notes, because I do add things to previous episodes when I find things that are relevant. I put them in. I just think that the evidence should be out there and laid out for everyone, for you to understand and dig in and empower yourselves. So anyways, have a great rest of your day. If you want to follow me on Instagram, if you want to follow me on YouTube, on Spotify, on Apple, that's where my internet face exists. Yeah. Have a good day.